You've probably seen the statistic. 99.98% of Americans can be re-identified from anonymized data. It's in vendor decks. It's in conference talks. It's usually followed by someone trying to sell you something. That number is real. It comes from a peer-reviewed study in Nature Communications, and it is being used to describe something it never measured. Today, I'm going to show you how HIPAA's Safe Harbor de-identification actually works. The real mechanism, not the summary. Why it was deliberately built to be simple. Why parts of it are still keyed to a census from the year 2000. And then I'm going to show you how AI re-identification actually works. 4 different methods, because they're not the same thing. And treating them as one is why this conversation is such a mess. Stick with me to the end, because I'm going to make an argument some of you are going to disagree with. And I want you to tell me if I'm wrong. Safe Harbor lives in 45 CFR section 164.514b2. It has 2 requirements, just 2. 1. Remove 18 categories of identifiers. 2. Have no actual knowledge that what's left could identify someone, alone or combined with other information. Do both, and something remarkable happens. The data stops being protected health information. Not less regulated, not lower risk. It falls outside HIPAA completely. No data use agreement, no minimum necessary, no accounting of disclosures. You can hand it to a vendor. You can publish it. That's a big deal, and it's why the standard matters so much. The 18 categories are what you'd expect. Names, social security numbers, medical record numbers, phone, fax, email, account numbers, license numbers, vehicle identifiers, device serial numbers, URLs, IP addresses, biometric identifiers, full face photos. Then 2 that trip people up. Geography. Nothing smaller than a state. You can keep the first 3 digits of a zip code, but only if all the zips sharing those 3 digits contain more than 20,000 people. Otherwise, it becomes 000. And dates. Every element of every date except the year, birth date, admission date, discharge date, death date. Plus, anyone over 89 gets aggregated into 90 or older. Here's the part almost nobody explains. Safe Harbor is deliberately mechanical. It's a checklist, not a risk assessment. And that was a choice, because the alternative, expert determination, requires hiring a qualified statistician to model your specific data set, your specific recipients, and your specific release conditions, and document that the re-identification risk is very small. By the way, the rule never defines very small. That's left to the expert. A 2-person clinic cannot do that. A 12-person startup cannot afford that. So HHS wrote a bright line. Remove these 18 things, attest to the second condition, and you're done. Any office manager can execute it. It's cheap, it's fast, and it's auditable. The price of that certainty is that the rule is context blind. It does not know whether your dataset covers 40,000 patients in Manhattan or 40 patients with a rare autoimmune condition in rural Montana. Same checklist, same legal outcome. Wildly different real-world risk. Hold on to that, because it's the whole ballgame. The privacy rule was published in 2000, effective 2003. The identifier list has never been revised. Not once. Not in the HITECH Act, not in the Omnibus Rule. The only update HHS has ever issued to Safe Harbor was a refreshed list of which 3-digit zip codes must be zeroed out. And that update was calculated from zip code tabulation areas created by the Census Bureau for the 2000 census. So the 20,000-person threshold, the thing deciding whether your patient's geography survives de-identification, is anchored to population data from a quarter-century ago. The HIPAA Journal's 2026 guidance says it plainly. The Safe Harbor identifier list is out of date, and organizations should get professional advice before relying on Section 164.514 alone. When that list was written, there was no Facebook, no smartphones, no consumer genomics, no data broker industry at anything like today's scale. No large language models. Which brings us to what the 18 categories don't cover. genomic sequences, wearable telemetry, your heart rate patterns, your sleep data, your step cadence, gait, keystroke dynamics, purchase histories, social graph data. And this one matters most for small practices, rare diagnoses. A rare diagnosis is not an identifier under Safe Harbor. Strip the 18 categories and it survives. But if you serve a small community, a rare condition plus a year plus a 3-digit zip can narrow the field to one person. The checklist says you're compliant, reality says otherwise. Now, the rule anticipated this. Sort of. There are two elastic parts, and almost everyone skips both. The first is identifier number 18. It's a catch-all. Any other unique identifying number, characteristic, or code. Characteristic. That word is doing enormous work. It means any field, even one that appears nowhere in categories 1 through 17, has to go if it could uniquely identify someone. That requires human judgment and domain knowledge. Automated tooling alone will not catch it. The second is the actual knowledge prong, and HHS gave us a specific example. In their own guidance, they describe a record where all 18 identifiers were removed, but an occupation field remained, and the occupation was distinctive enough that the entity must be deemed to have known it could identify the patient. Result? Not de-identified. The checklist wasn't enough. That's the part I want you to remember. Safe Harbor has a conscience clause built into it. Most compliance programs treat the 18 categories as the whole rule and never engage with the second condition at all. Okay, now the AI half. There are 4 distinct mechanisms, and conflating them is why this conversation goes sideways. 1. Linkage attacks, the classic. You take quasi-identifiers left in the de-identified data, dates, zip, age, gender, and match them against an identified external source. Voter rolls, data broker files, breach dumps, social media. LaTanya Sweeney demonstrated decades ago that zip code, gender, and date of birth alone uniquely identify roughly 87% of Americans. AI did not invent this attack. What AI changed is cost. Fuzzy matching across messy, incomplete, inconsistently formatted datasets used to require a research team and a grant. Now, it doesn't. 2. Generative modeling. This is Roche's actual contribution, and it's subtler than the headline. The old defense was, our release is only a sample, so an attacker can never be sure a match is the right person. Generative models estimate the probability that a match is both correct and unique, even from incomplete data. That defense is gone. And notice, that study measured pseudonymized data, records where names were swapped for codes, but the underlying details stayed. That is not Safe Harbor de-identification. It's the thing people call anonymized when they've only removed the obvious fields. 3. Unstructured clinical text. This is the underrated one. A 2024 review of 69 systems found modern machine learning de-identification of clinical notes hits above 98% token F1. Sounds excellent. 2% of a million notes is a lot of leaked names. And narrative detail. Patient's son coaches at the high school isn't an identifier any scrubber is looking for. 4. Biometric and signal re-identification. A study across 5 real-world ECG datasets re-identified individual participant IDs from waveform features alone with 82% accuracy. Gender at 76, age group at 67. Whether an ECG waveform counts as a biometric identifier under a list written in 2000 is genuinely unsettled. So, what's the actual risk? It depends entirely on what you did. Properly Safe Harbor de-identified data at scale sits low. National Center for Health Statistics figures put a population of 500,000 at roughly 0.4% risk. But watch what happens as the population shrinks. 100,000 people, about 3%. 25,000, about 10%. Small, rare, or geographically narrow populations are where Safe Harbor gets thin. If you're a specialty practice in a small market, that's you. Real-world attacks on health data have succeeded at roughly 26 to 34%, because most data in the wild was never properly de-identified. It was partially scrubbed. And a 2026 JAMIA analysis found more than 15 to 20% of individuals could be re-identified using common privacy-preserving matching tokens in U.S. representative populations. Minimal below 1 million records, rising fast above it. So here's my argument. Safe Harbor is not broken. It is doing exactly what it was designed to do: give organizations without statisticians a cheap, certain, auditable path to compliance. But Safe Harbor is a legal standard. It is not a security standard, and those were never the same thing. When you complete the checklist, you have earned a legal safe harbor. You have not earned a guarantee that no one can identify your patients. The rule never promised that. Vendors selling you fear are pretending it did, and vendors selling you complacency are pretending the gap doesn't exist. 3 things to do this week. 1. If your data covers a small population or includes rare diagnoses, Safe Harbor alone probably isn't enough. Look at expert determination. 2. Actually engage with the actual knowledge condition. Write down who reviewed the dataset and what they concluded. That's your audit trail. 3. Stop calling pseudonymized data de-identified. If you removed names and kept dates and 5-digit zips, you did not de-identify anything. Now, the argument I said you might disagree with. I think Safe Harbor should stay exactly as simple as it is. Every proposal to modernize it makes it more like expert determination, and that prices out the small practices who need a bright line most. I'd rather have an imperfect rule everyone can follow than a perfect rule only hospital systems can afford. Tell me where I'm wrong on that. I read every comment. And if you had to bet, does HHS revise the 18 identifiers before 2030? I'm saying no. Convince me otherwise. Subscribe to AI Privacy Advisors. Next in this series, what actually happens when someone reports a HIPAA violation? The whole process, start to finish.